Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Welcome to the Emerging Evidence in Myasthenia Gravis podcast series, Part 1. I'm Dr. Nick Silvestri, a professor of neurology at the University of Buffalo and Jacobs School of Medicine and Biomedical Sciences. Today I'm going to discuss important advancements in MG diagnosis. Accurate and early diagnosis remains critical, yet traditional approaches continue to pose significant challenges, especially for seronegative patients. Whether you're a neurologist, nurse practitioner, or allied health professional, today's episode is designed to help you recognize early signs of MG more confidently, leveraging emerging diagnostics, and understand how newer technologies are transforming the diagnostic journey, particularly in patients with seronegative MG or atypical presentations. Let's begin with where we are today. Diagnosing MG is both an art and a science. The classic presentation, fluctuating skeletal muscle weakness, especially involving ocular, bulbar, and proximal limb muscles, is often recognizable, but as you know, it's not always textbook. The traditional workup includes a focused neurological history and exam, antibody testing for acetylcholine receptor antibodies and sometimes MuSK antibodies, and electrodiagnosis including repetitive nerve stimulation or single fiber EMG. Yet these tools are not perfect. In fact, about 10 to 15% of MG patients test negative for both acetylcholine receptor and MuSK antibodies. These seronegative patients often experience delayed diagnosis, on average by several months to years, leading to disease progression and a compromised quality of life. That's where the recent advances come in. One of the most significant changes over the last few years is a broader use of high-sensitivity serological assays. At AAN 2025, multiple posters and symposia highlighted the utility of expanded antibody panels. In addition to AChR and MuSK, newer assays are now available to detect antibodies to LRP4, which is lipoprotein-related protein 4, agrin, and collagen Q. LRP4 is particularly notable. While not as common as acetylcholine receptor or MuSK antibodies, LRP4 antibodies have been identified in up to 2 to 5% of patients with myasthenia gravis, especially those with ocular or milder generalized symptoms. Agrin antibodies are even rarer, but may account for some of the previously unexplained cases. These advanced assays, now offered through select academic and commercial labs, use cell-based assays, or CBAs, or live flow cytometry platforms, significantly increasing sensitivity compared to traditional ELISA methods. Electrophysiologic testing remains indispensable, particularly single-fiber EMG, which has long been considered the most sensitive technique for identifying abnormal neuromuscular transmission. But let's face it, single-fiber EMG is technically demanding, time-consuming, and not always readily available. At this year's AAN meeting, several centers presented data on automated gender analysis systems which use machine learning to assist in detecting abnormal transmission with greater reproducibility and reduced operator dependence. Other highlights included high-density surface EMG, which is a non-invasive tool showing promise in detecting subclinical neuromuscular junction dysfunction, and ocular single-fiber EMG, which is particularly useful with isolated ptosis or diplopia, which we can often see in patients. While these tools are not yet mainstream, they're gaining traction in academic settings and may become more accessible over the next few years. What about AI? Artificial intelligence and machine learning are being explored for early detection of neuromuscular diseases, including myasthenia gravis. Although not yet in routine use, this is a signal of where we're headed. Decision support tools to aid but not replace the clinician, especially in community settings where access to subspecialty care may be limited. Let's move to ocular MG. This often presents subtly, ptosis and diplopia that fluctuate throughout the day, and is frequently misattributed to fatigue, aging, or other causes. Recent data reinforce the importance of early diagnosis in ocular MG to prevent progression to generalized disease. A key AAN 2025 takeaway is that patients with ocular symptoms and borderline or negative antibody tests still benefit from early electrophysiological evaluation and close follow-up. Remember, up to 50% of patients with ocular myasthenia gravis will generalize within 2 years without early treatment. So that means early recognition and intervention matter. So how should this all change your practice? Let's distill this into actionable takeaways. Number 1, test beyond acetylcholine receptor and MuSK antibodies. If the initial antibody panels are negative and suspicion remains high, consider extended testing for LRP4 and agrin through referral centers or commercial labs offering cell-based assays. 2, use electrophysiology proactively, especially in seronegative or ocular presentations. Don't wait to order single fiber EMG or repetitive nerve stimulation. If it's not available where you practice, refer out early. 3, know your diagnostic allies. High-density EMG and automated jitter analysis are still evolving, but consider enrolling difficult-to-diagnose patients in research networks where these tools are being validated. 4, document clinical fluctuations. Encourage patients to record symptom fluctuations, perhaps photos of ptosis at different times of day, for example. This can provide valuable diagnostic clues. And finally, collaborate with specialists. When in doubt, don't delay referral to neuromuscular specialists. Early expert input can accelerate diagnosis and avoid months of ineffective treatment. What are the barriers of implementation and how can we address them? While the tools are improving, access remains a challenge. Many community settings lack access to single fiber EMG or antibody panels beyond acetylcholine receptor antibodies, and insurance coverage is inconsistent. Clinician awareness of newer serotypes like LRP4 remains low. So what can we do? We can educate, include MG diagnostic updates in your CM programs. We can advocate, work with lab directors and administrators to increase access to newer assays. We can network. We can build referral pathways with regional neuromuscular centers. And we can leverage technology. We can use telehealth to connect patients with MG specialists for sound opinions and diagnostic guidance. So what are some closing reflections? The diagnostic landscape for myasthenia gravis is changing, and fast. What once required months of trial and error can now be clarified within weeks using modern tools. From expanded antibody panels to cutting-edge EMG and AI support, we are entering a new area of precision diagnosis in MG. The more quickly and accurately we can diagnose MG, especially in those with atypical or seronegative disease, the sooner we can initiate appropriate effective treatment. And that ultimately means better outcomes, fewer crises, and improved quality of life for our patients. Thank you so much for joining episode 1 of Emerging Evidence in Myasthenia Gravis. In our next episode, we'll shift gears and explore therapeutic options, including extended dosing data, self-administration options, and how treatments like zilucoplan, efgartigimod, and rozanolixizumab are reshaping MG care. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credit, access downloadable slides, as well as other topic segments and case scenarios. Until next time, stay informed and keep leading with knowledge.